Um, when you are dealing with developmental epileptic encephalopathies, you're treating an entire family and sometimes a community. And so when you are able to make a difference, you're not just impacting one person. And it's just particularly rewarding to be part of that team of people caring for the patient. Um, so I've developed some like little catchphrases. Over the years in my practice, I have come to believe very strongly that the greatest threat to the well-being and quality of life of patients with severe developmental encephalopathy is complacency. And complacency by maybe the caregiver or the treating doctors. And I understand how that develops. You know, when you have tried 17 drugs and surgeries and diets, and your loved one is still having seizures, you sometimes lose hope. And and you know, one of my passions of late is to fight against that, because there have been and there are is will continue to be exciting new developments specifically targeting Lennox-Gastaut and Dravet syndrome, as well as some other rare epilepsy syndromes with new targeted treatments that are more effective. And so I really want to combat that sense of futility. So it's my new mission is to educate patients and families and providers, so doctors, nurses, to the importance of trying new therapies and not giving up, with the goal of reducing harm and improving quality of life. Um, so I wanted to start out with a recent online survey that was very patient focused in the Dravet world. And for those who aren't familiar, Dravet is a very specific epilepsy syndrome that for over 85% of patients is caused by a single gene mutation in a gene called the SCN1A gene. And that gene is a sodium channel in the brain that's responsible for excitatory brain signaling and and well, and also inhibition, and it underfunctions. And so the main category of most of our anti-seizure medications for many years are sodium channel blockers, and they make patients with Dravet much worse because you're blocking a channel that is already underperforming. So Dravet is a very specific syndrome that impacts brain development, so cognition, so thinking, behaviors, motor skills, and causes epilepsy that generally begins in the first year of life. So patients and families with Dravet were surveyed, so 492 caregivers, and some of the results that were found is that the majority of patients had onset of symptoms in that first year. More than 50% are diagnosed by the age of 3, but also more than 50% were initially diagnosed with a different disorder, and therefore may have been put on some of those medications that make them worse. 80% ultimately had genetic testing. A good third are dissatisfied with seizure control. Over half report low, so poor to moderate seizure control, and we'll get into more detail. Almost 60% were looking for new treatments. And a majority of the survey respondents were family members of pediatric patients, and close to 90% were living at home as opposed to an institution or a group home. So presenting age and symptoms, 10% were diagnosed after age 18. And I definitely have had that experience of patients who did not get a Dravet diagnosis until they were adults. But fortunately, most are diagnosed by age 3. 86% of the time, it's seizures that are the initial symptoms. Sometimes it's a high fever with cognitive delay or the neurodevelopmental and behavior issues. Most patients with Dravet have poor seizure control. So only, well, good seizure control is considered 5 or less seizures per month, and 45% of patients achieve that. But a good 30% have more than 20 a month. And the rest, about 25%, are anywhere from 6 to 20 seizures per month. And for most caregivers, seizures are the most important concern. Upwards of 40% are looking for new therapies, so not satisfied with where things are. And in terms of quality of life, only 25%, or right around 25%, say that they are good, satisfied, or extremely satisfied with the patient's quality of life. So that means we have a lot of room for improvement. So over 75% of patients their family members really feel that life could be better. Okay, and the most common challenges, other than specifically with seizures, is the day-to-day management of symptoms, namely seizures, but also behavioral dyscontrol. So we don't want to leave out Lennox-Gastaut syndrome. Lennox-Gastaut is harder to define because it's not one gene, it's not one cause. It truly is a syndrome. I believe it's underdiagnosed. So when I say LGS, that is short for Lennox-Gastaut syndrome. It impacts about 40 to 45,000 patients in the US. In my practice, in the past year, I've seen about 1,200 patients, and 65 have Lennox-Gastaut syndrome. Right, so it's a small percent, but it's a really important percent, and the stories are powerful. The syndrome is diagnosed when patients present with a combination of multiple seizure types that are hard to control, associated with developmental delays. And then in childhood, their EEGs can have a specific pattern that we in neurology look for called slow spike wave. As they get older, things can change. Seizure types could be 100 a month in infancy and sort of settle down in adulthood to half that, even if you don't change the medicines. Daytime seizures can become less, but seizures in sleep are often highly resistant and persist into adulthood. And with the uncontrolled seizures, there is lifelong and to a degree progressive loss of developmental function. And then, of course, patients with uncontrolled seizures have higher rates of injury and shortened lifespans because of that. The EEG changes over time and is less obvious, but that multiple seizure types, and the most common being drop seizures that sort of give you the diagnosis of Lennox-Gastaut. So The kids that should be wearing helmets or are presenting wearing helmets, that is almost certainly someone with Lennox-Gastaut. And because the seizures are really hard to control, often, the treatment goals are a little different. We want to prevent the most life-threatening and serious seizures, the drop seizures, and the generalized tonic-clonic seizures, while we also don't want to worsen their behavioral issues. We don't want to over-medicate them, so we want to preserve best quality of life. So we need to find that balance of seizure and harm reduction, and without compromise to quality of life. Back to the Dravet patient family survey, when looked at what people are doing to manage their seizures, 96% of patients take prescription medications. A third have used the diet to try and manage the seizures. A third of patients have used medicinal marijuana that is unregulated. So CBD, Charlotte Webb's oil, different medicinal dispensary products. 25% have sought surgery, including vagal nerve stimulator or corpus callosotomy, and then 3% of others. There's been consensus among seizure experts for both Dravet and LGS that there's a sort of hierarchy of preferred treatments now. And first line for these generalized tonic-clonic and drop seizures is valproic acid or Depakote and clobazam. And then if patients are not controlled or cannot tolerate these medications, second line, so the next add-on therapy should be fenfluramine, or specifically for Dravet, steripental with clobazam. Steripental is marketed as Diacommit, and fenfluramine is Fintepla. Okay, so Fintepla or Diacommit. Diacommit is given with clobazam. And the other second-line therapies, a lot of patients and families will be more familiar with Topamax or topiramate, cannabidiol, the prescription Epidiolex that is, has been tested in clinical trials and can be received by prescription, covered by insurance. Also second-line ketogenic diet. And congratulations, Maine. Our new pediatric epileptologist, Tiffany McDonough, has brought a keto dietitian to Maine Medical Center, and we will be starting a pediatric keto program at Maine Medical Center. So keep your eyes out. You no longer have to work through Boston. All right, so thank you, Tiffany McDonough. Third line therapies: levetiracetam, brivaracetam, zonisamide, Fycompa, ethosuximide, vagal nerve stimulation, and corpus callosotomy. And interestingly, if you go and you look at patients, or you may be thinking of your family members, and you're wondering, wait, why have I tried all the third line therapies and maybe one or two of the second line, but no one's ever talked to me about the diet or Fintepla or Diacommit? So that's a good question, and that's one of the reasons we're having this talk tonight. And there are some very new and active experiments going on. I am not mentioning all of them, but the responsive neurostimulator in the centromedian nucleus of the thalamus, so deep brain stimulation, is being tested in Lennox-Gastaut syndrome for tonic and tonic-clonic seizures. There's a medication out there that's approved for a different genetic disorder that causes severe epilepsy, ganaxolone, but that is also now in trials for LGS. And for Dravet syndrome, there are some gene therapies and something called antisense oligoclonal antibodies. Oh no, not antibodies. I'm sorry. ASOs that impact RNA and gene expression without actually changing the DNA. And we're not inserting genes into people's chromosomes. I'll prepare better on another day to talk about ASOs. So I was asked to spend a little time, and actually the rest of the talk until we do questions and answers, I'm going to talk about Fintepla or fenfluramine. I am not being paid by UCB for this talk. I am a consultant for them, and I do some professional speaking on Fintepla, but this is for my good friend Christine and the patients and families for Epilepsy Foundation. It is important, though, when talking about a drug to be upfront with any safety concerns and also deal with some myths and misperceptions about what the safety issues are. So Fintepla is FDA approved to treat seizures associated with Dravet and LGS in patients 2 years and older. And it's only available through a program called REMS, which is a risk mitigation program that's mandated by the FDA. And the reason Fintepla has a REMS program is that the ingredient fenfluramine is a serotonin receptor agonist or stimulator, right? So it's pro-serotonin. And in the past, drugs that are pro-serotonin, including fenfluramine, have been associated with valve problems in the heart, so leaky valves, and pulmonary artery hypertension. And I can answer questions about that. This is when fenfluramine was given to obese patients back in the 70s and 80s and 90s. At a much higher dose than is used in epilepsy and in combination with the stimulant. And that was a drug called fen-phen. And at that time, no one knew that serotonergic stimulating drugs had this kind of cardiac impact. So no one was looking, and a handful of patients got pretty sick. And that's why fen-phen was pulled from the market. Fenfluramine for epilepsy is used without stimulants at a much lower dose, and we are monitoring the heart to avoid this condition, to look for it before it becomes symptomatic. And we'll talk about it was not found during clinical development. It's given as a twice daily liquid. It's cherry flavored. It's okay with the diet, so there's no sugar in it. Can be taken with or without food. It works with feeding tubes. And yeah, there's no dietary restrictions, and there's no interactions with any of the seizure medications that are typically used. Now, it is the impact of Fintepla in Dravet syndrome that got the FDA to, allow clinical development, and because it is so impressive. So in something called a double-blind placebo-controlled trial over 14 weeks in a clinical FDA-monitored study, Fintepla reduced monthly seizure counts in Dravet patients 79%. And that is compared to the sugar solution, the placebo, where only 16% reduction in monthly seizure counts were seen. So sometimes hope has an effect. That's called the placebo effect. But 80% compared to 16% is dramatic. And that is patients that were randomized to the full dose, which is a weight-based dose in children, and a fixed amount in patients over 100 pounds. Patients, 50% of patients had 21 days or longer consecutive seizure-free. And that's compared to the longest seizure-free in the placebo group being 8 days. So 50% of patients got up to 3 weeks seizure-free. This is in the 14 weeks where families didn't know if they were getting the drug or the sugar solution. So when a patient volunteers for a study and they're in that placebo-controlled phase for the usually 3 months or 14 weeks, once they complete that, they're offered something called open label extension, where you know you're getting the drug. So everyone that was getting the drug now knows they're getting it. And the people that were getting the placebo are offered the drugs, right? And then they can stay on the medication as long as they want to until the drug is FDA approved. And that allows the company to look at long-term safety and efficacy. So 94% of patients that went into the blind part of the trial stayed with it and got into the open label extension. And so these patients were on the drug for 3 years, and 64% got a better than 50% reduction in their seizures. And that includes 41% that had more than 75% reduction in seizures. So if you were having 20 seizures a month, you were getting down to 4 seizures a month or better. So this is really exciting. In comparison, although you never compare, these two drugs are never compared head to head, but Epidiolex numbers were half of what we see in the responder rates generally. So it's pretty dramatic. In Lennox-Gastaut, it is highly impactful, not quite to the degree of Dravet patients. In that 14-week blinded phase, the monthly seizure reduction was 24% compared to 9% for patients taking placebo, and that's 2.7 times better than placebo. This was a highly treatment-resistant group who have already tried at least 7 other seizure meds, or an average of 7 different seizure meds, and we're still having an average of 194 drop seizures a month. Drop seizures being tonic, atonic, tonic-clonic seizures, 194 a month. Right? These patients also 75% were children, and 25% were adults. Also, 94% continued into the open label extension, and 50% of patients got up to a week seizure-free, right? When beforehand, the longest they had gone is 1 or 2 days seizure-free. A quarter of patients on Fintepla for LGS are super responders, right? And a quarter of patients will get more than 17 consecutive days seizure-free. Similarly, about a quarter of patients are considered to be significantly improved by both the caregivers and the doctors. And that was true of the pediatrics and the adult patients. So about a quarter of patients are rated to be very much improved or improved, all right, compared to before. And in the adults, so this Fintepla trial for both Dravet and Lennox-Gastaut, they looked at cognitive function and executive function. They did behavior scales, rating scales, and about a quarter to a third of patients taking Fintepla had improved behavior control, improved executive function, compared to less than 5%, up to 8% of the placebo group. So these are small numbers of patients, but it was still statistically significant. So again, somewhere between a quarter to a third of patients with improved behavior. So Fintepla does have side effects, and the most common in the Dravet study was decreased appetite, some diarrhea, low energy, decreased weight, respiratory infections, fevers, some problems with balance and walking. And the slides can be available to look at. In LGS, diarrhea, tiredness, vomiting, sleepiness, decreased appetite. Only 6% of patients, though, actually dropped out of the study because of side effects. And, in a clinical trial, patients are forced to increase the dose at a specific rate. So in clinical practice, where you can go up on the dose more slowly, it is rarely side effects that are causing my patients to stop this drug. When it is, though, it'll be, in my patient experience, it's been fatigue. And then some patients, the opposite, getting very, very hyper. But most that have stopped because it didn't work. In terms of the safety monitoring, the REMS program is pretty simple and straightforward. And the idea is if this drug can possibly impact heart valves or pulmonary artery pressure, we're going to screen for it and look for it before there's ever a symptom. And so in the clinical trials, these studies were done before anyone was exposed, and every 3 weeks to a month, and then every 2 months, and then every 3 months, over and over and over. Once the drug was FDA approved, and none of the patients in the studies that went on for more than 3 years, none of them had any abnormalities or warning signs. So the FDA has us do a baseline study, and then twice a year, as long as you're taking it. So every 6 months. And then if you stop it, there's one more echo 3 to 6 months after stopping. So twice a year, non-invasive, and echo doesn't hurt, is really less monitoring than the blood work you need to do for patients taking Depakote in the first couple years of therapy. So it is not a significant burden when the drug works. So 341 patients with Dravet, 262 patients with LGS were exposed to Fintepla through the clinical trials, including the 3 to 5 years of open label extension, and none developed any problems in the heart valves or in the pressure of the arteries in the lungs. And so that does include patients being followed for more than 5 years. There is a clinical nurse educator that the company who makes Fintepla, UCB, has, where if your own neurologist doesn't have the time to really go over the data, there is a nurse educator that'll answer questions and go through the information one-on-one. So a lot of the end of the slides are, again, the safety concerns and more information, sort of like at the end of those TV commercials with all the potential side effects. Some of the other side effects that we have seen and potential is serotonin syndrome, which is also something that can occur, say, in adults taking an antidepressant. So Zoloft, Prozac, Celexa, any drug that is pro-serotonin can result in excessive serotonin, causing symptoms of rapid heartbeat, agitation, restlessness, twitching. And so looking for those symptoms is important. When I have patients who are on, say, a little bit of Prozac or sertraline for OCD behaviors or to calm them for anxiety, when I start Fintepla, I cut the dose in half. And if I have a patient on a stimulant, like for ADHD, I cut that in half. And oftentimes I end up stopping it because they no longer need it on the Fintepla. But it's very important if you as a provider are going to meet with the neurologist and want to talk about Fintepla, that they really know all the medications that other docs may be providing to avoid side effects and sort of extra drug interactions. And we don't stop Fintepla abruptly. We wean it off. I think that I would very much like to take questions from people that are on, and then if there are none, I can talk a little about some of the patients. I don't have slides for them, but I can talk about some of my both dramatic successes and then patients that didn't respond so well. But it was a very easy to go on and to go off of it because it doesn't interact with any of the meds that they're already on. So it's just 2 weeks to get up to speed, watch for a month, and if it doesn't work, 2 weeks to go off of it, and no harm, no foul. And then when it works, it's really great and exciting. But Christine, if you want to take questions.
I can do that. We actually have one already. Are all the drugs you mentioned brand name, not generic? I understand generic may be different.
Oh, so when I had the slide up about the drugs, I was using all the generic names. But if the question is, are the drugs available as brand name, as generics? So Fintepla is only available brand name. And that Diacommit, the steripental, that was the generic name, the brand name Diacommit. There is no generic substitution. And then of all the other drugs I mentioned, Riviact is one that has no generic yet, but it will in 2025 or early 2026. I can go back if you wanted. Oh, and then Epidiolex does not have a generic. The CBD oil that's a prescription is brand name. And then all the experimental drugs are only available in clinical trials.
The next question is, how successful have gene therapies been for Dravet syndrome? In your opinion, how hopeful are you for the future of gene therapy in treatment of Dravet?
Okay. So right now, the most promising therapies are not exactly gene therapies. They're these ASO. And ASOs are pieces of code of RNA that affect gene transcription. So it will either promote more production of the deficient gene or stop something that is preventing transcription. So ASOs are based on the genetic code, but they're not inserting new genes. And so just to be clear, right now, nobody is making an SCN1A gene and getting it into the nucleus of cells the way that they have done with sickle cell. All right, like there's one patient, I believe, with sickle cell anemia who has like a hemoglobin gene using that slicing technique. I can't remember. So the ASO therapies that are in clinical trial for Dravet have been very exciting and are disease modifying, and they're looking at more than seizure reduction. They're looking at development. But I'd be happy to put together something reviewing those trials because we're still in phase 3 and the publications of the earlier phase 2 studies, though, are exciting. They are harder, though. They're injections into the spinal fluid, and figuring out how often that needs to be done to get a persistent benefit is also a very long process. So I have not jumped all into the ASO therapies. I'm happy to work with anyone to help identify where those clinical trials are going on. We had hoped to bring one to Maine, but haven't been able to do that. Any other questions? Do you want to hear a story or two?
That would be great.
Okay. I will not use patients' names. So I have a patient who is a 56-year-old woman with the first initial of T. And she is someone that I have treated for the entire 22 years I've been in Maine. And when I first started treating her, she lived at home with mom. And she was still on Dilantin, Tegretol, phenobarbital, and maybe had tried some ancient drugs and was having 50 to 60 drop seizures a month And of those, at least 10 to 20 were tonic-clonic. And, even Diastat hadn't quite come on board until a couple of years into my life here in Maine. So this poor woman, had a helmet, had multiple broken bones, lost most of her teeth. Oops. Hold on, that's my son. Uh, do not disturb doesn't include your family. Um, so, over the years, we tried some of those medicines like Topamax, Keppra, Briviact. We did vagal nerve stimulation, which was very helpful. We did corpus callosotomy, which gave her 5 months of seizure freedom and um, a wonderful change in personality from being very annoyed all the time and needing to be sedated to have the vagus nerve stimulator interrogated to happy to see me, talkative about little life events like holidays and birthdays. So we made progress, but up through from 2018 until Fintepla came out in 2022, the best we could do was happy, alert, not off balance, but still 30 seizures a month, 25 to 30, 5 tonic-clonic, so that was better, and the rest, the tonic stiffening seizures. And so she still fell because she was ambulatory, still had to wear the helmet. And but the combination that we had got before Fintepla was clobazam, Epidiolex, Briviact, and maybe one other drug. I can't remember. And then with the Fintepla, we have gotten, and it's been 2 years now, because she was an early person, we have less than 5 seizures a month consistently now for over 2 years. They're all just as she's falling asleep. So she is now ambulatory. She still wears the helmet just in case, but she hasn't had a fall in 2 years. And we've been able to reduce, but not eliminate, the clobazam. And we did get off clonazepam. And that's great. And we didn't lose any of the happiness that she had. Another one of my patients, M, who's a young man, who's just 22 or so, he had a lot of behavior discontrol and used to have to come to my office with like 2 staff plus a family member. And we made a lot of changes before going to Fintepla. The most impactful was the vagus nerve stimulator. But in order to program that vagus nerve stimulator, I would have to bear hug this young man and dance behind him while he's walking through the room. And when we're sitting and talking, I have to sit with my chair against the door so he doesn't walk out. And the reason he takes 2 staff traveling to visits is one has to be in the back seat to make sure he doesn't unlock the door to walk out of the car. I mean, behavior discontrol. And 25 to 30 seizures a month. Again, it was the best I could do. And we started Fintepla in September of 2023 on a September 13th. And within the first month, he went 21 days seizure free. He had, I think, 15 seizures the next month, and then 2 in December, and like 3 in January, and consistently getting 2 weeks, 10 days, seizure free. And he can now come to a visit with one staff and one family member, and mom and sister can take him out to like lunch from the group home and not require anyone to come with. And, not everybody. So I've prescribed Fintepla. I did the numbers, 30. Well, I can do it backwards. I have 22 patients taking it and 9 who've quit and 2 that are in the early process where I can't say how they're doing. So 21 plus 30, I don't know, about 35 times. And no disasters. So, and about a third of the time we end up stopping it because it doesn't work. But the others, those 2 are superstars. But I just saw someone else, JB, and he's gotten a week seizure free, and he was having 3 to 4 seizures a day. And he hasn't had a generalized tonic-clonic seizure since starting Fintepla, and really the much more minor seizures. And the parents aren't blown away because he's got a little, he's fidgety, but they said it's annoying, but he's not annoyed or uncomfortable. And they said they would trade the fidgety for the tonic-clonic seizures, hands down. So a range of experiences. I also have had very positive responses to diacommit, the stiripentol, with a recent Dravet patient of mine, where we got him off a bunch of sodium channel drugs he shouldn't have been on, got him on diacommit with clobazam, and got like a 70% reduction in seizures. But then we also added Fintepla, and now this guy is like 95% less seizures than when we met. And family that hadn't seen him in a while are like, what happened? We now have this vibrant young man. So not seizure free, and with an oral infection, still has clusters. But when things are going well, so much better than it was. So
Um, Dr. Henninger, we have another question. Do you have any research on the correlation between vitamin B and seizure reduction in Dravet?
I'm sorry, I don't. Vitamin B or D?
Vitamin B.
B. So all I know about is vitamin B6 and pyridoxine deficiency. So pyridoxine deficiency, there's a genetic defect where a handful of even in the womb babies start seizing because they have absolutely no B6 pyridoxine. And the only thing that treats it is B6, and they will need B6 the rest of their lives. And the other role of B6 is can help with the agitation associated with Keppra, taking daily B6, but I do not know of research about B vitamins in Dravet. The only other comment about vitamins in our patients that have multiple disabilities, and we live in Maine, almost everybody is D deficient And you should be checking vitamin D3 levels every year through your pediatrician and repleting them. Because also, if your loved one is not ambulatory or not highly ambulatory because of drop seizures, they're at risk of osteoporosis as they get older. So please check your vitamin D. Can make them more comfortable too if they were deficient. Any other
Thank you.
questions?
We do. I thought I
Okay.
remembered hearing that there is a drug interaction between steripental and fenfluramine. Is that true?
There is. It's very predictable. It's when a patient is already on steripental, and this is why I added fenfluramine to steripental instead of doing it backwards. Um, they can, their maximum dose is 3.5 milligrams twice daily. It's on the prescribing. I only have one that's on both, but it just limits the dose. And it's only that limiting the dose is the way that you take less Lamictal when someone's on Depakote. Because it inhibits the breakdown of it, they're getting the full dose. But they just need half the amount to get the full effect. So, yes, that is true.
Also, the other question was about being in the sun for too long in the heat with children with Dravet. Have you heard about any of that as well in your research?
Well, I have, and actually I've experienced this in many poor patients that have refractory epilepsy. So, and I will write letters, and it is not BSing to the in CMP that people absolutely have to have air conditioning. The brain does not like getting overheated, and it will exacerbate many neurologic things. So epilepsy is definitely heat sensitive. I don't know that Dravet is more so than any other sort of severe epilepsy, because I have patients with juvenile myoclonic epilepsy, post-stroke epilepsy, that if they get over, and then normal people can have seizures if they get hyperthermic. So I think that we definitely, with global warming and more hot days in Maine, you definitely have to be careful, and patients will have seizures provoked by get excessively heat, dehydration. And then some people, the sun has the added effect of flickering from glare and triggering visual provoke seizures. So definitely have to keep people cool, not just Dravet.
Exactly. And there's and exactly someone noted too that many Dravet patients can't regulate body temperatures and they can't sweat. Um their
And
own,
some of
I
the
think their own
drugs do that. Zonisamide can do that, can reduce your sweating and make you prone to getting overheated.
very true. We're at 7:57 right now. I'm not sure. And then yes, Joseph just said I heard about that, about zonisamide. I think that if anybody else has any other questions, I'm not sure if anybody else does. Dr. Henninger, if after this webinar is finished, if people have questions that they email me, are you okay if I reach out to you and send those questions to you
Of course,
for future questions to be answered? Great. We want to
absolutely.
thank you so much for being here tonight with us and spending your own personal time with us. I appreciate that. Seeing you and talking with you is always a delight. But
Thank,
being able to share you with the rest of the epilepsy community is also wonderful. So thank
thank
you
you for
again.
thank you for inviting me.
Oh, I'm so glad you were here. But we will have this recorded. So we are happy to share that with all of you. And if you have anybody that was not able to make it, please share that with them. Share it on your social media. And like I said, if you have any additional questions for Dr. Henninger, I'm happy to get them to her. Also, if you haven't looked at our upcoming other webinars that we have coming up for our events, please do so. We have some really great ones that are coming up. So thank you, all of you, for being here tonight, and have a great evening.
Bye, thank you.
Bye, guys. Thank you.